Funding for This Is Nashville comes from you, our listeners, and Music City Prep Clinic, Nashville-based provider for PrEP and offering comprehensive sexual health services in an environment designed to be safe, professional, and shame-free. Learn more at musiccityprep.org.
I'm Blake Farmer, and this is Nashville. I think it's fair to say that nobody wants to be called geriatric. Can I get a witness from anyone who gave birth after 35? Getting labeled as having a geriatric pregnancy is rarely a badge of honor, and that's long before age has really taken the toll that may put us in the care of a geriatrician. But today, we're going to try to reclaim the G word. We're meeting physicians and healthcare leaders in Middle Tennessee who specialize in helping us age well, not just lengthen our lifespan, but help us improve our health span, which is a term you'll hear several times today. It's a slight reframing that may help us all embrace geriatrics. This episode, by the way, is part of our Next Age series, made possible thanks in part to BlueCross BlueShield of Tennessee and the West End Home Foundation. We'll start with a patient who was more eager than most to find a geriatrician. Jean Gold-Yeager is 87, retired from Vanderbilt, where she basically led the patient complaint department. So she knew who she wanted to be her geriatrician because she knew who complaints came in for, and that was Dr. James Powers, who is also with us right by her. Welcome to you both.
Thank you.
Thank you.
Well, we're also streaming video today. If you want to join us visually in the studio, just hit play under the live tab at youtube.com/@WPLN. Hello, waving to the video audience. All right, so Jean, so you really did, you never heard a bad word from patients about Dr. Powers in the patient affairs department at Vanderbilt?
No, I did not. And he wasn't alone. There were many, many, many others that I did not hear bad
I didn't mean to
things
suggest
about.
the complaints were rolling in all the time.
Right.
Yeah.
But I also chose him because he's younger than I am, and I did not want my doctor dying before I did.
Oh, what an interesting calculation there. So when was this? Like in your 50s that you started?
Oh, no.
Okay.
I was in my late 60s, I think. I had always thought that the only time you went to a doctor was when you were sick.
Yeah.
If something went wrong, you went to a doctor.
Yeah. Well, when did that mindset change?
Well, it changed when I got educated by my physician that it was important to have regular checkups because you could get things early and intervene before there was a major problem.
Yeah. So how did you go about your search for the right geriatrician for you in your late 60s?
Well, because I had an inside track, that always helped. And I knew that Dr. Powers was a geriatrician and that he was younger, and he met all my criteria. He had not had a complaint, and he was younger, and that's basically what it was.
I like to focus on the younger here. Dr. Powers, do many of your patients say, I'd like for you to be younger than me? That's key.
That is actually true.
Really?
And they grab me by the arm as they leave the office and say, "Don't you retire."
Well, have you, is that a consideration?
Yes, it is, of course. But on the other hand, we realize that people do have life events and have to move on, and all of us have to change.
Well, it's interesting, though, that this particular physician, when you're choosing someone, you kind of think about picking somebody who's going to be with you for the long haul. Is that part of this discussion when you're intaking a new patient?
I think, yes, that is true. And it also reflects the fact that people really value the continuity of care, someone who knows you over time. And that's rare to find these days, but is so valuable, particularly when we're treating older adults. To know what their values are, what their wishes are, is so very important in how we care for them.
Well, how long have you, I was going to say described yourself as a geriatrician, but I think you actually officially are a geriatrician. When did that transition happen?
Well, geriatrics is a relatively new field. It's only really been around. The first exam, if you will, was 1988. So that's relatively young.
And this is like where you'd be board certified in geriatrics?
That's correct. So I helped write that exam, and so I've been around, predated that. But basically, geriatrics is a new focus on maintaining health in older adults. We function in many different areas, long-term care facilities, hospital, clinics. We do a lot of consultations. We actually try to work with our colleagues in other fields, internal medicine, family medicine, cardiology, to try to make them, if you will, good geriatricians for their own patients.
Wow. Well, at the time, were you already basically a geriatrician without the title? Was your practice leaning toward older patients?
Sure, it was. I'm an internist, and as an internist, you take care of many people with chronic illness. So a good portion of your patients are going to be in the older age group.
Can you introduce us to this thing that I didn't know about before prepping for this episode, which is Stanford's New Map of Life project? There's a lot of emphasis on like helping people live 100 years, but kind of having a new sort of thinking about how you maintain folks through those years. What is this new map of life concept?
Yes, the Aging Center at Stanford has looked at our increasing longevity. Do you know that in about another 30 years, we will have 1 million centenarians in the United States?
Wow.
We've never before in human history had that many older adults living with us. And so the planning that they are emphasizing is that we should look at a lifespan as 100 years. Obviously, we won't all make it to 100, but if we can plan for that, if we can actually make the life valuable and really help people to understand that they have a long way to go and to take care of themselves. Prevention is very important, so that lifespan is really one that brings a lot of joy and comfort throughout the lifespan.
Well, Gene, what's that meant for you as you kind of think about, I don't know, do you think about 100 years?
Yes, I do. The women in my family have lived far into their 90s, and so I expect that I will too. One of the concerns that older people have is, will I outlast my money?
Yeah.
So that is an issue for older people.
And it seems so separate from getting medical care, but really they're really it's all tangled up.
Yes, it is.
Yeah. Well, what have you done? Is there any sort of secret to your general good health at 87 years old?
Well, I'm trying to take the advice of my geriatrician. And
who's listening?
Yes, and exercise.
Yeah.
Lose weight, which has always been a horrible issue for me, but I am following his advice now. And so those are two things, exercising and losing weight. Of course, I haven't smoked for a long time. I do occasionally have a nice gin and tonic, and I'm trying to limit those to maybe once a week. So I'm trying to follow the advice of my doctor, plus other people. There are a lot of other people, other professions that can help. Nutritionists, for example, physical therapists, social workers. All of them that have had training in gerontology can help with this, and are a help to the physician too.
Yeah. Well, you're here because I think Dr. Powers feels you're a model patient. But how often does that mean you see him in a year? I mean, are you annual wellness visit? Anything else during the course of a year?
I plan on going once a year.
Yeah.
But if anything comes up in the meantime that I'm concerned about, then I call.
Yeah.
And I can either get a phone consultation, or he may advise me to come in so I can be checked.
Yeah.
And so that's how that works.
Well, Dr. Powers, what makes a geriatrician all that different from an internist, a family medicine doctor? Like what are you trained in that others are not?
I think it's the comfort in managing chronic illness, in care management, and kind of connecting the dots. So that's actually the main thing that many of our new patients ask for, is someone who can kind of put the pieces together. I can see my specialist, but they don't know what the other specialists are doing, and I'm lost.
And by chronic conditions, you're talking about, maybe diabetes, hypertension, high cholesterol. What is it you're managing most commonly?
Sure, all of those things. Of particular importance is increasing number of people with dementia. That is a very complicated illness to manage, and there aren't enough specialists to take care of them. So really, primary care is doing a lot of that. So we consult a lot with our colleagues and help them to manage those patients. I have a large number of them myself.
So you're saying that there's a lot that you can do rather than having to send them to, like, I guess, a neurologist? Is that where they would go after you?
That's right. For some of these chronic illnesses, it's the management. It's not a new diagnosis so much. It's caring for them, helping people to cope with them, helping their families, working with the caregivers. So there's a lot to it.
If you're just joining us, I'm Blake Farmer. This is Nashville. We're all going to get there eventually. We're talking geriatrics today and seeing the latter years of medicine a little differently than we have before. And a reminder, we are streaming video from the studio today. If you'd like to get a visual experience today, youtube.com/@WPLN. So, Gene, when did you sort of start to see this value in focusing on preventive care? You said that previously in your life, you kind of thought you go to the doctor when you're sick only. And you've been getting more preventive care. Have you seen the benefits that you could point to clearly?
I have seen that for myself, of course, but I've also seen it in my friends. The quicker you can get onto a problem, the greater the likelihood that you'll have a successful outcome.
Yeah.
And so that has been a primary motivator to doing this for me. And, when you think about it, geriatricians and pediatricians have a lot in common because the pediatrician and the geriatrician, their patient population is getting older, and their bodies are changing rapidly, and that's true on both ends of the continuum for little children and for older people.
Yeah.
So,
well, we have a nursing professor on later from MTSU who started out in neonatal nursing.
There you go.
And now is working out the other end. Dr. Powers, does that resonate for you?
Yes, absolutely. I think the same skill set for the healthcare professional, taking care of a vulnerable population, dealing with family members as caregivers, and dealing with the community for services is exactly the same.
Yeah. So outside of caring for chronic conditions, kind of managing all that, since, whether it's memory care or it's other chronic conditions, how much of what you're doing for patients is sort of making sure they maintain things like community connections, hobbies, that kind of thing? I mean, does Jean talk to you about her painting, which I've seen some of them, and they're lovely?
Thank you.
Yes, indeed. In fact, if the healthcare professional realizes the importance of talking about those things, the bond that it creates, the more in-depth knowledge you have of the patient, it's so much more valuable. And we don't talk about these things all of the time, but I would say that in a typical visit for a patient that I've been following for a while, that might be 30% of our conversation. And so it's continuing the relationship, which is so very important when we have to make hard decisions. And sometimes that happens. Those are sad times, but if you're prepared for that, if you know the patient, if the family and you can talk with the patient and you can discuss these goals of care, we call them, it's just so much better for everybody.
So, Jean, you're 20 years into geriatric care, but was it difficult to get accustomed to that G word?
No, I don't even call him a geriatrician. I just talk about my doctor.
Yeah.
Which I think most people would prefer that term anyway.
Yeah. Well, do you find, though, that folks in your circle are maybe scared off at the prospect of finding someone who might be their last doctor?
The people that I know and associate with don't have any problem thinking about the aging process, and they're more likely to do studies about it, to try to learn more about it, and to be responsible patients, be responsible themselves for their care. You can't expect the doctor to do everything.
Yeah. Dr. Powers, what surprises some of your patients, maybe who are not reading as much as Jean is, about the care they're going to receive from you? And I ask this because in my mind I know one of the big questions you talk about all the time is like fall prevention.
Yes.
That kind of thing. But I wonder what surprises your patients who come into your care?
We end up taking away medications. We end up telling people they don't need to do certain tests.
Wait, talk about why that is, the taking away of medicines and tests.
Medications in particular. Older adults take more medications proportionately than any other portion of the population. And if you can reduce or eliminate unnecessary medications, you can prevent a lot of complications. There are a lot of side effects to medicines. It's believed that 20% of hospitalized patients have some major complication from medication. Some of these are necessary medicines, so they're very potent agents and should be used cautiously. So sometimes reducing is actually helpful.
Yeah.
Improve cognitive function, reduce fall risk, for example. So we do a lot of that. We also tell people they're doing fine. We encourage them. We become cheerleaders. That's kind of fun. And actually, when you ask questions about past work, about their families, about their hobbies, to get to know them better, they actually really enjoy that. So those are surprising to many of our patients.
Jean, have you experienced any of this less is more phenomenon from Dr. Powers?
No, I think I was pretty well informed initially because of what I had experienced in my own family with a family member who was on too many medications and medication that did not work well with each other, and really had some bad outcome as a result of that until she was able to get off the medication. So I knew about the importance of that before I even started going to Dr. Powers.
Well, Jean, why don't you wrap us up here? Any word to the wise for those who are on the market for a geriatrician?
Well, sometimes it's hard to know how to find a geriatrician.
There aren't many in the state.
Well, I always, and you're not going to like this, but I always go to Google. And,
I like that. That's fine.
Dr. Powers has told me,
I see.
Stay off of Google, because I tend to want to diagnose myself.
Oh, boy. This just now coming out when we have to wrap it up. All right, let's get Dr. Google out of here. Jean, thank you. All right, so stay off. Search Google for a geriatrician and then leave it at that. Is that what you're leaving?
Yeah, sure.
All right.
Yeah.
Well, Dr. James Powers is going to stick with us. Jean Gold-Yeager, thank you so much for sharing your experience as a model patient here. We need to take a quick break. When we come back, we're going to talk about the shortage of geriatricians and some of what's drawing young doctors into the specialty. In fact, we have one of the youngest geriatricians in town here in the studio. So stay with us. This is Nashville.
Funding for This Is Nashville comes from you, our listeners, and Music City Prep Clinic, Nashville-based provider for PrEP and offering comprehensive sexual health services in an environment designed to be safe, professional, and shame-free. Learn more at musiccityprep.org.
I'm Blake Farmer, and this is Nashville. At last count, there were only 74 board-certified geriatricians across the entire state of Tennessee. 74. It is a specialty that is more in demand as our population ages, but there are fewer physicians getting into this late-stage medicine. Dr. James Powers of Vanderbilt is still with us, and we're joined by Dr. Stacy Smith, who started her training at Meharry Medical College, just finished her fellowship at Vanderbilt, and adds one to the state's list of trained geriatricians. Welcome to This is Nashville.
Thank you. Thank you for having me.
And we're streaming video today. If you want to join us visually in the studio, just hit play under the live tab at youtube.com/@WPLN. Dr. Smith, why are new physicians not necessarily drawn to geriatrics?
I was surprised when I was in medical school that more people weren't kind of going into it because it seemed pretty fascinating to me, and I liked having the older patient population. I think there is a lot. I don't think a lot of people know as much about it, so they kind of assume that if I'm treating an older patient, I would treat him the same as
I see.
A younger
What's
patient.
The difference?
There is more variety, I think. When you look at patients who are maybe over 75, like one 80-year-old is going to look nothing like another 80-year-old. And so you really have to treat the person more than, just the age or, like the epidemiology, like the studies and so forth. So I think that's pretty exciting, but I'm not sure everybody has kind of realized it. But hopefully they will.
You're saying that two 15-year-olds are going to have pretty similar experience, but if you have an 80-year-old person who has had all sorts of medical complications and they were a smoker or whatever, compared to someone who has, been on the Mediterranean diet all their life or something, you got two very different 80-year-olds.
Exactly.
Okay.
Yes.
Well, what originally drew you down this path?
Well, I always had an interest in it. My parents are probably the older baby boomer generation. My aunt was one of my best friends growing up, and she is 96 right now.
Wow.
She has dementia at the moment, but we were always hanging out when I was younger. I just had so much fun with her. I remember her and my other aunt kind of saying that, their doctors, they didn't feel like they cared, like what was going on. And so they didn't really want to go to the doctor. And so I always thought, well, if I'm a doctor, then, these are the patients that I would like to treat.
So you sort of have an affinity, a natural bedside manner with folks who are in your aunt's demographic.
Yes.
I like that. So. And they encouraged you that way, it sounds like.
Yes, they did. They did. Like, inadvertently, just by complaining about the care that they might have had before. But yes.
Well, Dr. Powers, are there efforts to incentivize physicians to get into this specialty? Like, are we at that point? Is there that much of a shortage?
There really is. There are only about 6,000 geriatricians in the country. By comparison, there are 6 times as many cardiologists.
Yeah.
But there are many more older adults that could benefit from the care of geriatricians. So we have a two-pronged approach. One is that we realize that in the near future, we'll never have enough geriatricians to take care of all of the patients that could benefit from it. So our goal in a teaching setting is to make sure that our new trainees, medical trainees, are good geriatricians for their own patients, whether they're going to be orthopedists or family doctors. That's so very true. But I think that there is some hope for the future. What we do in geriatrics is we're cost avoidance as far as a business principle. And what that means is that we try to improve quality, reduce unnecessary cost, improve outcomes as best we can. And that makes sense if you have value-based purchasing. If it's just fee-for-service and a profit motive, unfortunately, that works against a lot of our geriatric principles.
Well, and you've thrown out a lot of terms here, but like fee-for-service is talking about like essentially just listen, if somebody shows up at the ER 5 times, great, they're paying every time, or Medicare is. But when you have this sort of value-based mindset, it says, if we can handle this in the office with your geriatrician, wouldn't that be better for all of us, even if it produces less revenue?
That's right. Sometimes I have to tell the boss, I may not make you money, but I can save you a lot.
Really?
So that's a whole different mindset.
So that really is a discussion. I mean, because obviously, a health system like Vanderbilt's quite a business. You have to kind of remind that the value is not just in dollars and cents.
Correct.
Yeah. Well, I do want to get into a little bit of that. I sort of full disclosure here. I for a couple of years was gone from WPLN, was working in value-based care for a startup here called Wellvana, but it opened my eyes to all that's going on for seniors related to value-based care. So this is like if you're on Medicare or a Medicare Advantage plan, the private insurers, that the physician can kind of be incentivized to help care for them and be able to, if they're able to create savings, like you don't show up at the ER so much, they get to get in on some of the profits there. I'm wondering, Dr. Smith, if this is a big draw for folks that like, oh, there's a new opportunity with Medicare patients to work for these organizations that do value-based care. Does that change some of the calculation about whether this is a good specialty to be in right now?
I think it is a little bit to an extent. I don't know if I know of some colleagues who have gone into that, both who have done training specifically for geriatrics and some who haven't, because it's not necessarily required to work for them to have a specialty in geriatrics. But it is a nice model in the sense, or to an extent, in the sense that you have everything is supposed to be there to take care of your patient. So helping them get medications, helping them get to their appointments, all the kind of social things that sometimes social determinants of health that sometimes get lost, in general medicine. So I do think there is kind of a draw to that. I do think there is a need for more kind of education about the geriatric population still, because while you can get the job there, you also want to be, serve your patients well, and not knowing the kind of the ins and outs of what's appropriate for an older adult versus, the general population would be really helpful in those settings. And I think if we had a little bit more training that specialized in geriatrics, that would help even more, like with those systems, and help the doctors wanting to go into those systems, be successful in that.
Yeah. Well, and you're even seeing specialized clinics that are popping up. Some of them are Centerwell, which is essentially from Humana, ChinMed, which does the same kind of thing. There's one not too far from here in Metro Center. Is there some value in having these clinics that just focus on seniors?
I think so. One of my colleagues who finished the fellowship with me last year is working for one of these organizations. She just started, so I don't know everything that she was saying about it. But it's a nice model, to have everything there and have it kind of focused on, because there does need to be a lot more, I think, attention paid to the geriatric population. One, just because it's growing, and two, because we're all hopefully get there at some point. So, having something special set up for that population is a good thing, I think.
Yeah.
No matter what.
Well, Dr. Powers, you were talking about sort of making sure that all physicians who are trained, know how to work with patients who are in this demographic. But yeah, doesn't every physician outside of pediatrics maybe need to know how to work with seniors?
Oh, we agree 100%. And in fact, a lot of training requirements for these programs require some geriatric training. We have all kinds of healthcare trainees that rotate through our different services. And in fact, our geriatric graduates from our fellowship program are highly sought after for health systems that are forward-thinking. Some of these changes we talked about are relatively recent, and it's only a small portion of the marketplace, perhaps 20%. But increasingly, I think they're finding the economic value of having a geriatric plan in-house.
So maybe not as directly a revenue producer like a surgeons or like cardiologists, but they're seeing it as, listen, there's real incentive here when you're talking about a cost avoidance.
That's correct. They're really geriatric programs involved with taking care of your higher risk patients in one population, patient-centered medical home, reducing the return admission rate to the hospital, very important for healthcare systems these days, and they're all using geriatric principles.
If you're just tuning in, this is Nashville, and I'm your host, Blake Farmer. We're talking about geriatrics today, the care that's available in Middle Tennessee, and what kind of shortage is expected in the coming years. We're streaming video at youtube.com/@WPLN. Dr. Smith, you're so the most recently out of this. What if you're training specifically for geriatrics, how does that training look different?
Well, it looks different probably in most aspects in terms of medication is a big one, because, medication is in all facets, comes to all facets of medicine. But when you get to the older generation, these medications don't work the same as they would in someone younger.
Wait, talk about that. You're saying that you could give the same medication, let's pretend it's one pill. You give it to a 25-year-old, you give it to an 85-year-old, different effect.
Yes, exactly. And not everybody knows that, because not all the studies will include people who are, over a certain age.
Yeah.
And so to be aware of that is a big one, because like Dr. Powers was saying earlier, and I was listening in, the wrong medication given to like an older patient can have disastrous effects.
Yeah.
And so that's one of the things that we kind of learned about. And then we also kind of went through all the different specialties that I had done in my residency, whether it's like, psychiatrics or, orthopedics or, all of the different specialties, and just kind of see how it was different with older adults and some of the obstacles older adults face. So it was just kind of a dive deeper into the things that I was learning during residency, and it was pretty great.
Yeah, well, I worked with a pharmacist whose term was medication misadventures was what you were trying to avoid, because people have so many pills too. They sort of get creative and they're like, oh, I went to the hospital, they gave me this, so I'm going to stop taking that. And I'm sure you run into this on the daily of people getting creative.
Quite a bit, yes.
Yeah.
Yes. Uh-huh.
Well, talk to me about memory care, and I guess not memory care, but just that even as a primary care for someone who's in this age group, there's probably going to be a discussion about memory. What does that look like at a base level for your patients?
Well, a lot of the patients are concerned, about losing their memory or memory deficits as they get older. Sometimes there is a greater deficit than others. I learned during my fellowship and partially from Dr. Powers that, everyone comes to the idea, or most people think as we get older, if I don't remember things, that's fine. That's normal. That's what's supposed to happen. And I learned through my fellowship and the practice of my patients, it's common, but it's not normal. It's not something that you should just expect, much like, most other things when you get older, saying that, I have pain, constantly, but I guess it's just because I'm older. It's not something you necessarily have to settle for, because it's not just a normal part of aging, even if it is common.
Yeah.
So with memory, there are various tests and, cognitive assessments that we can kind of do to see where someone's baseline is, and then look at their function and how they're living their life, if they need help with different things. But it is a big part of the discussion generally with most of my patients, sometimes more warranted than others, and the patient's families.
You're saying that people may be concerned and they want to talk about it, but you're able to allay their fears, and then there's others who go down a testing route.
Right.
Yeah.
But either way, you can prepare for it. If you have an idea of where you are, you'll have a better idea of where you might be going.
Yeah. How do patients handle the geriatric term? Do you find that you try to sort of downplay that you're a geriatrician?
I did. Mostly when I'm inpatient, I say I specialize in the care of older adults.
I see.
I don't know if it's them or it's just me being scared I'm going to offend someone. Most of the time, patients will make a joke about it, you know, and just be like, oh, the geriatrics must be here for me, or something like that. But I try to be more sensitive about it. But, most of the time people just have a good chuckle about it.
Well, Dr. Powers, what's your go-to joke?
Well, as far as the name, older adults is actually the preferred terms.
Yes.
It turns out we've actually done some studies on this. The American Geriatric Society has done this. And as far as a joke, I think it's fair. I had this gentleman come in, and he was having some pain in his right knee, and it was very uncomfortable as I examined him. And he said, now, Doc, don't tell me it's just because I'm old, because the left knee doesn't hurt. It's just the right knee.
Well, all right. So you didn't say it was just because he's old. I like it. All right. Last thing, for people who are listening and thinking, listen, I like my doctor. Why should I get a new one just because, I'm a Medicare patient now. I'm 65. What's the pitch for finding a geriatric specialist? I may go to both of you. Dr. Powers first.
It is difficult to find a geriatrician. As you mentioned, we have less than 100 in Tennessee. We've got 6,000 across the country. We estimate we could use 6 times that many. In the near future, we won't have that many. So it is our hope that with new training requirements, that internist, that family doctor who you do see, that nurse practitioner, that physician's assistant, they all have had geriatric training requirements, will be a good provider for that older adult. So that's our hope.
Dr. Smith?
I get asked a lot, like, what makes geriatricians, different, and kind of the draw. I don't generally need to market myself too much because there are so few of us. But I do agree with Dr. Powers. The more knowledge that's out there about serving the geriatric population, I would say if you're comfortable with your doctor, you stick with your doctor. I just think that it's on us to keep educating our doctors, and healthcare professionals about how to care for the geriatric population, because like I said, all of us are going to get there at some point, and it's a pretty big one.
That's the basis of many of our consultations, by the way. Rather than transfer care to us, we often will talk up the referring physician, say they're doing a fine job. Here are our recommendations, and please let us know if we can be of further help.
Well, you are a force multiplier out there in the internist world. Dr. Powers, Dr. Smith, both from Vanderbilt's Division of Geriatrics, thank you so much for being here today.
Thank you.
Thank you.
We're going to take one more break. When we come back, we're going to venture out of the exam room, talk about an approach to geriatrics that also includes age-friendly communities. We've got leaders from the Matthew Walker Clinic and MTSU's Positive Aging Consortium, so stay with us. This is Nashville.
Funding for This is Nashville comes from you, our listeners, and Music City Prep Clinic, Nashville-based provider for PrEP, and offering comprehensive sexual health services in an environment designed to be safe, professional, and shame-free. Learn more at musiccityprep.org.
I'm Blake Farmer, and this is Nashville. Even for seniors who have a lot of chronic conditions, diabetes, high blood pressure, high cholesterol, they don't spend that many hours in a year with their geriatrician or their doctor otherwise. It's all that happens outside an exam room that can really get people moving toward thinking about extending their health span, as we've been talking about today, not just focused on their lifespan. Deborah Lee is a nursing professor at MTSU and the co-founder and director of the Positive Aging Consortium. Welcome to This is Nashville.
Thank you, Blake. It's wonderful to be here today.
Katina Beard is the CEO of Matthew Walker Comprehensive Health Center, which has a program called SALT that we're going to talk about. Welcome.
Thank you so much.
We're also streaming video today. If you want to join us visually, it's youtube.com/@WPLN. It's under the live tab if you're getting lost over there. All right, Katina, SALT. I think it stands for Seasoned Adults Living Triumphantly.
Yes.
What does living triumphantly look like?
Yeah. So for us, it's looking like individuals who have community, who are engaged, who have opportunities to continue to find benefit in their community, and being able to live an optimal life and just experiencing things at their age that they find of interest and just progressing as they're aging. So seasoned adults living triumphantly.
So what is the, is this just for patients who get their medical care at Matthew Walker?
No. It's a program that's open to anyone in the community. The only criteria is that you are 60 years old or older, which I was happy to hear because I'm getting close to 50-something. And that's the only criteria. There is no cost to the participant. And they are just able to meet at the health center.
So there's meeting, sort of community building, but what does it do to kind of promote that triumphant living?
Yeah, and so what we found is the connectedness, the social connectedness, and so there are healthcare frameworks that talk about individuals that are socially connected have better health outcomes. They have better mental health. They have better physical health. And so having that community, it has been important. And so as people age, right, they kind of get disconnected because their mobility has slowed down. They're not working. Their children have moved. And in some places, they just don't feel safe coming outside of their home. Right. And so being able to provide this opportunity for our residents, our community members, to be able to engage with one another helps them to have this livelihood in their lives.
Yeah, what was the Surgeon General's report from several years ago about social isolation was akin to smoking a pack of cigarettes every day or something?
Yeah.
The health effects.
Yeah.
Is that something you see that there's real measurable? Not that you're measuring it necessarily, but that you can see improvement when people just get out of their houses, get together.
Yeah, I can. I think we see it anecdotally, right? They come in, they're a little shy, they're a little withdrawn. A couple of months later, they're engaged. We've had some participants that really have bonded, some that are still much more mobile than others. Maybe they're still driving. They have a routine. They're helping some of the participants move on with some of their daily activities, right? And so helping them get to the doctor or making appointments as their mental capacity is declining or their physical capacity is declining. And so they found community. They found new family in this group. And so it's really been great to see that come about.
Yeah. Deborah Lee, take us, drop us in on Murfreesboro. I mean, is some of this, I know you all do some work with local senior centers, but the Positive Aging Consortium, what does the actual work look like of that group?
Well, the actual work of that group started in 2019, which Dr. Brandon Grubbs, who was with you last month, he and I co-founded that together. And that is, a bunch of us as faculty who have come together, who have an interest in older adults, either through our service work, our research, or what we teach on campus. And what we realized is that in order to do the work, which the work is to provide educational opportunities for older adults, to have an age-friendly campus, which, by the way, MTSU is the first and only university in the state that is designated as age-friendly through the Age-Friendly University Global Network.
Yes.
So Dr. Brandon talked about that with you last month. But also to provide opportunities for our students to go out in the community. And, we did COVID clinics, we do flu shots. We go to St. Clair Street Senior Center and provide opportunities through learning and through their health fair. But the Positive Aging Consortium, I think our biggest contribution is threefold. But the biggest thing we've been doing is we have a Positive Aging Conference every other year. Our third conference is coming up in April of next year on the 17th. And what we do, it's a conference for older adults. And it's not very often that there are conferences for older adults out there. It's
interesting, because I thought you were going to talk to me about how, a bunch of researchers get together or something. You're saying this is really, this is for the people who you serve.
Yes, it is. And it's for all the reasons that Katina talked about. It's a place for them to come together and learn things about what they can do to age well. So we have different speakers, and we do have people who do research, but the whole idea is, what is that research telling us that we can use practically? Yeah. How can I apply what the research tells us to my life to help me learn, live a life of quality? And that's really what older adults want. The years they have, they want them to be quality years. So we really, we love doing it. We get amazing results from the older adults who are there. They absolutely love it. We make it a special day. We've been able to keep the registration fee at $35 because of the generosity of our sponsors. So we are doing that. We also we have an aging studies program at the university as well. And we also have a postgraduate certificate in gerontology. So our other focus is, how do we educate the workforce, the next workforce that's coming out of our program, to work with older adults? So that's a huge need that we have.
So these would be your folks who are getting their bachelor's in nursing or something.
Correct. Yeah. Psychology, social work, nutrition, child and family studies, all of those programs have. And sociology is another big one we have that produces students who we want to go out and work with older adults.
Katina, can you talk about how when you gather folks together, it's just a very different interaction than maybe like a doctor-patient relationship. It's kind of like a little group therapy. Maybe they hear a message that they'd heard directly from their doctor, but it hits a little differently when you're kind of out in the community. Is that part of the idea here of like, that there's a lot you can do that doesn't require medicine?
Sure. Some of it is clinical. Yes, we do talk about how to be safe in your home, right? Trips and falls, those types of things, how to, talk to your doctor about medication, how to get your discussion points ready when you get ready to go to the doctor. But it's really more about life. Like, it's really about, hey, here's some opportunities. Hey, because I want to take this conference back, right, and see how we can get some of our participants there. It's about, this is what's going on in your community. These are ways for you to be safe online or as you're going out to the grocery store, right? Because as you age, right, you may become fearful, right? I can't go out. I don't want to go to that store. I don't want to do. And so how can you still feel safe? How can you be safe around your loved ones? Because what we found is that sometimes they get taken advantage of by some of their loved ones, right? And so it's a compilation of thoughts and topics. And so much like your conference, we have a senior expo that we have in May during Older Adults Month. May is Older Adults Month. And so we have a senior expo where we bring different vendors to our site that have resources for people who are older, so that they can have that as a resource, as information. And then we just kind of expose them to different opportunities and activities in Nashville. So health is a part of it, but it's also more of a holistic lifestyle.
If you're just tuning in, I'm Blake Farmer. This is Nashville. We're wrapping up our hour on geriatric medicine and beyond in Middle Tennessee with a trip outside the exam room here. Reminder, we're streaming at youtube.com/@WPLN if you want to watch this conversation. Katina, I wonder if do you find seniors often feel like it's the doctor who's going to solve their issues, rather than, a discussion?
Yeah, listen, sure. That I think, yes, I think they trust their provider. Mm-hmm. They are very serious about who their provider is. Mm-hmm. And we have lots of capable providers in our system. And maybe Dr. Junior is booked. Well, Ms. Frazier, she wants to see her doctor, right? She doesn't want to see, and we get it, right? Because they've built this trusted relationship. And we want them to take that message out to other older adults who may not be connected into healthcare, to help them build a trusted relationship with their provider so that they can have better health outcomes, right? We want them to have what they need, their medication, their therapy, their referrals. We want to be able to help them navigate this very difficult system of healthcare so that they can achieve their health outcomes.
Mm-hmm. Deborah, how much of your all's work is just helping people navigate Medicare, which can be so much different than a private health plan or that kind of thing?
Yeah. Well, we don't do, that's not part of the scope of what we do in terms of helping people, because it's very hard to understand, by the way. I'm getting ready to start learning because I'm going to be there next year. And it is a hard thing to navigate. The good news is there are navigators for Medicare. There are people out there. I have resources of people who do that. So if I were to get a question, I can refer someone who can give them the correct guidance for that. Because we want people to have accurate, of course, information so they can make the decision that's best for their life.
Mm-hmm. Yeah, well, I imagine that's what's part of what's at these expos and that sort of thing that you all are getting. Well, Deborah, are you seeing a shift? We've been talking about this shifting thinking of thinking about your health span rather than lifespan, basically a quality of life conversation. Are you finding that is top of mind for people in this demographic?
Absolutely.
Yeah.
The reality is that people want to be able to do what they can do for as long as they can. The things that give them joy, spending time with family, traveling. And it's important to them that am I doing the things I need to do to be able to continue to do the activities that are important to me for as long as I can. And the good news is that, programs like Katina is doing, other things that get people out in the community, get them connected, help them learn more about what they can do to improve their health and well-being. And I think the best thing people can do is, if they can, is get out of their home and be around other people. Because just what you said about the Surgeon General's report, we know what isolation and loneliness does to people. It affects not just their physical health, but their mental health significantly.
Yeah. Well, Katina, though, I imagine there's all sorts of barriers, even just getting people to your center, even if they don't live far away. How do you all get across those barriers, whether it's transportation or just their mobility? Yeah.
And so we will help organize transportation for them if they need it. We do have a large good number of them that still drive. And we plan it early in the day so they can come out early so they're not out when it's dark. And so we try to address some of those low-hanging barriers, but definitely know someone that wants to come to SALT, that we will help arrange their transportation for them. And after that, everything is very accessible because of the building and all of that. And so, yeah.
All right, so if somebody's hearing about this SALT program for the first time, like, it sounds like something I should probably do. How do they get involved?
Yeah, so you're going to contact Gwen Langley, and her phone number is 615-327-9400, and her extension is 5991.
All right,
and we meet on first and third Tuesdays.
First and third Tuesdays at, I assume, the Matthew
the
Walker
clinic.
the one on Jefferson Street?
Yes, 1035 14th Avenue North.
All right. Well, and I don't know, Deborah, there's several things that you've mentioned, but how would people get involved, let's say, for this conference that's coming up in April?
Yes, so you can go to mtsu.edu/PAC, which stands for Positive Aging Consortium. We will be posting about the conference soon. Registration will open in February. For that.
And otherwise, is the main way they might be interacting with students and that sort of thing, is it the senior centers you all work closest with?
Yes. We work closely with St. Clair Street Senior Center, which is literally like 2 miles from the university.
Right.
We have a very close relationship with them. We have membership in our Positive Aging Consortium from the Senior Center. We also have other individuals who work with older adults as part of the consortium as well. So the consortium is not just people from MTSU, it's also community members.
Well, we also have links on today's show post for both both for SALT and for the Positive Aging Consortium. Katina Beard is CEO of Matthew Walker. Deborah Lee is the co-founder of the Positive Aging Consortium at MTSU. Thank you both for helping grapple with the G word today, geriatrics.
Thank you so much.
Thanks for tuning in this hour. This is Nashville is a production of Nashville Public Radio. Tomorrow is a roundabout episode where our panel takes your calls, and rather than just focusing on headlines of the week, this week we're inspecting whether Nashville nice is still a thing. We have great guests to help us examine the evidence on this, including Demetria Kaladimos, now of the Nashville Banner. Are people here nicer than other places you've lived? Is it a facade? Do you see our smile and wave culture changing as we grow? You can call in live tomorrow, or if you'd like to call now, leave us a voicemail ahead of time at 615-751-2500. Today's episode was produced by LaTanya Turner. Special thanks to the sponsors of our Next Stage series, BlueCross BlueShield of Tennessee and the West End Home Foundation. We were directed today, I believe, back there by Mary Mancini. Our board operator is Liv Lombardi. The masterminds behind our theme music are LaRange and Namir Blade. Tasha A.F. Limley is our managing editor. This is Nashville. I'm Blake Farmer. Go in peace.